Hello and good afternoon, everybody. I am very honored to be the moderator of today's IMS webinar, and it's a very, very important topic, which is which is paramount for everybody who is counseling menopausal women. It's about management of menopause in patients with obesity, and I'm very honored to be the moderator today for two excellent speakers, which are Professor John Stevenson from the UK and Professor Santiago Palacios from Madrid. Next slide, please. So I have to tell you, before this webinar was supported by an unrestricted educational grant from Beza Healthcare. Beza Healthcare had no role in the selection of topics, selection of speakers, and they have not vetted, reviewed the content of the speaker's presentation. And please back to the previous slide. And now it's my great pleasure to introduce Professor John Stevenson. He's a quietly well-known speaker, and he has published a lot of articles about the topic of menopause. Professor Stevenson is Emeritus Reader in Metabolic Medicine in the National Heart and Lung Institute, Imperial College London. He also is a visiting professor at the Belgrade School of Medicine and consultant physician at the Royal Brompton Hospital. And dear John, thank you that you're here with us, and you will share your opinions about menopause in obese patients and cardiovascular risk. It's a very important topic, I think, and who else could speak about that more, how would you say, well, knowingly than you. So this is your stage, John, and I'm happy to listen to your lecture.
Thank you very much, Catherine. It's a pleasure to be able to join in this webinar, and I've been asked to talk about menopause in obese patients and their cardiovascular risk. These things are very, very closely linked together. I just got to my disclosures, and I want to start off just by showing this study, the huge study from Selim Yusuf, worldwide study looking at coronary heart disease risk factors in both men and women. And you can see the common factors that are shown here on the left hand side: smoking, cigarette smoking, high cholesterol, diabetes, a particular risk factor, hypertension, and here abdominal obesity. So obesity is a very important risk factor for coronary heart disease in both men and women. And particularly it's abdominal obesity. It's where you actually keep your fat. And then we've got the protective factors shown on the right here, the diet good in fruit and vegetables, moderate alcohol intake, and physical exercise. These are protective factors. So if we look at what are the actual cardiovascular risk factors associated with obesity, and this list just shows you the various things that are linked. Lipid abnormalities in patients who are obese, they tend to have raised triglycerides, they tend to have a low high-density lipoprotein cholesterol, HDL cholesterol, and of course HDL tends to be a protective factor. The low density lipoprotein cholesterol, which of course is the bad one, the levels in obese patients sometimes are raised, but not always. But more importantly, they will have increased amounts of the small dense LDL particles. These are the very atherogenic particles. In terms of glucose and insulin metabolism, then obese people tend to be insulin resistant, and because of that, they will often have raised glucose levels and certainly raised insulin levels. Raised blood pressure is another feature in obesity, and this is partly due to the fact that the patients are insulin resistant, and insulin resistance is associated with raised blood pressure. They tend to have increased sympathetic nervous system activity, which will increase the blood pressure. And lastly, they will have increased levels of certain adipocytokines, which are also linked to raised blood pressure and hypertension. And then lastly, obese people have an increased risk of thrombosis due to the fact that they have an increased risk or an increased coagulation process, then they tend to have reduced fibrinolysis. So the balance between coagulation and fibrinolysis is perturbed. So people who are obese will often have what we call the metabolic syndrome. And here the importance of insulin resistance is highlighted. Insulin resistance is a pivotal disturbance for the metabolic syndrome, and it links together all these other abnormalities that form the syndrome. So again, central obesity, a very important feature, lipid abnormalities, high blood pressure, impaired glucose tolerance, coagulation disturbances. All of these are features of the metabolic syndrome. All of them will contribute to an increased risk of coronary heart disease. So if you become insulin resistant, this tends to make you gain weight in a central distribution. If you gain weight in a central distribution, this makes you more insulin resistant. So people who do gain weight and start to become obese, they're going to worsen their insulin resistance. And as the insulin resistance gets worse, that will make them gain even more weight, which will make them even more insulin resistant, and so on. So you get into a vicious spiral of weight gain and increasing insulin resistance. And this is one of the major problems. Why is insulin resistance so important for cardiovascular disease? Because of its associations, as I've already mentioned, with hypertension, with dyslipidemia, that's going to be low HDL, raised triglycerides, more of the small dense LDL particles. Insulin resistance, of course, is a feature of type 2 diabetes, and the type 2 diabetics tend to have raised blood glucose levels, but also raised insulin levels, which are actually bad for the cardiovascular system. Insulin resistance is associated, as I've already mentioned, with obesity and with coagulation disturbances. So the major effects of being obese are that you've got this increased risk of developing coronary heart disease and also of developing type 2 diabetes. Now, I've shown you this slide already, looking at the risk factors, but now I'm adding in an extra one for women, and that is the menopause, because this is a coronary heart disease risk factor exclusive to women, the menopause. So what I want to do now is to look at the effect of menopause on these various cardiovascular risk factors and show you how they actually will add to the risks that are already present if you are obese. The menopause results in adverse changes in a number of metabolic factors. And we published many years ago the fact that the menopause appears to result in a metabolic syndrome. You have abnormalities of lipids and lipoproteins due to the menopause, adverse changes in them, adverse changes in glucose and insulin metabolism, adverse changes in body fat distribution, increases in blood pressure, and abnormalities with coagulation and fibrinolysis. So this is the result of the menopause itself, but we know that the metabolic syndrome is responsible for probably up to about half of cardiovascular events that are seen in women with the metabolic syndrome. So menopause results in an increase in total cholesterol, an increase in LDL cholesterol, and a decrease in HDL cholesterol, and its important subfraction HDL2. Results in an increase in triglycerides, results in an increase in lipoprotein little a, it results in an increase in the small, dense LDL particles, which are particularly atherogenic. And it probably also increases LDL oxidation, which is an important part of the atherogenic process. When we look at what happens as the result of menopause in terms of glucose and insulin metabolism, this was a big study of well over 5,000 women. Over a third were postmenopausal, and median age of menopause was 49. And these women were all screened with oral glucose tolerance tests. But then they divided them according to their menopausal status, and they adjusted for other confounding variables such as body weight and so on. And what they showed was that premenopausal women, a much smaller percentage, had impaired glucose tolerance compared to the postmenopausal women. So almost twice as many postmenopausal women actually showed impaired glucose tolerance compared with premenopausal women. And our studies have shown that although there's no immediate change in the circulating levels of insulin between pre and postmenopausal women as they go through the menopause, there is actually quite a big difference in terms of insulin dynamics. And there is a reduction in incremental pancreatic insulin secretion, but there's also an increase in the insulin half-life, which is why, although there's this reduction in insulin secretion, if you're just measuring peripheral levels, they don't appear to have changed. That's masking these important changes that have occurred. And what we find with insulin sensitivity is that there's a steady decline in insulin sensitivity following the menopause. So in other words, following the menopause, women become increasingly insulin resistant. And we were able to show that the abnormalities in terms of insulin responses to a glucose challenge were linked to the menopausal age, but were irrespective of the chronological age, and also linked with the BMI. So just to summarize what we see in terms of the menopause and glucose and insulin, no immediate change in the fasting levels or in insulin sensitivity, but thereafter there is a steady decline in insulin sensitivity. So these women are becoming more and more insulin resistant, decreased pancreatic insulin secretion, and a decrease in plasma insulin clearance. Now, this is a meta-analysis that was produced by my friend and colleague, Panagiotis Anagnostis, looking at over 190,000 postmenopausal women, of whom over 20,000 had type 2 diabetes. And he looked to see which women had had an early menopause, that's a menopause below the age of 45, and which women had premature ovarian insufficiency, which would be below the age of 40, and compared them to women with normal age of menopause between 45 and 55. And in the early menopause women, and particularly in those with premature ovarian insufficiency, there was a significant increase in terms of the incidence of type 2 diabetes. Other factors that are important to consider, there's alterations in body fat distribution, which I'll show you in a second, increases in blood pressure following the menopause, hemostatic changes, increases in inflammatory markers, and of course obesity is associated with an increase in inflammatory markers anyhow, and there's evidence for impaired vascular endothelial function following the menopause. So these are other factors to bear in mind. And these are one of our old studies looking at body composition, where we had close on a couple of hundred pre and postmenopausal women that we adjusted for their chronological age and adjusted for all other confounding variables. So we're just looking at the effect of menopause itself. And you can see that the postmenopausal women have a significant increase in their central fat distribution, the male pattern or android fat distribution. And at the same time, a significant decrease in the proportion of fat that they have in the female or gynoid distribution. What happens to blood pressure following the menopause? Well, probably there is an increase in blood pressure following the menopause. And certainly, again, my colleague Panagiotis Anagnostis has shown that following early menopause, there's a clear increase in arterial hypertension. And so there's an increased incidence of hypertension following the menopause. So let's just finish off by looking at what happens then if we give HRT and try and reverse the menopause. So for most forms of HRT, we'll get a decrease in total cholesterol because estrogen decreases LDL cholesterol. There may be an increase in HDL cholesterol or a decrease in HDL cholesterol, depending on the route of administration of the estrogen and also depending on the addition of progestogens. There are decreases in lipoprotein a, an increase clearance of the small dense LDL particles, and an increase of the clearance of the postprandial lipid particles. So these are all the very atherogenic particles, and probably a decrease in LDL oxidative damage. So you can see the beneficial effects that the estrogen will have. In terms of glucose and insulin metabolism, then this varies somewhat to the type of estrogen that you're giving. Conjugated equine estrogens at high doses impair glucose tolerance, whereas estradiol 17 beta tends to improve glucose tolerance, particularly if you give it orally, more so than if you give it transdermally. Conjugated equine estrogens result in an increased insulin response to a glucose challenge, which is an unwanted thing, whereas the estradiol 17 beta actually results in a decreased insulin response to a glucose challenge. Again, more so if you give it orally than transdermally. When you add progestogens, the androgenic progestogens actually increase insulin resistance, whereas the non-androgenic progestogens, oral micronized progesterone, or the very similar dydrogesterone will have little or no adverse effect on glucose and insulin metabolism. So when we're looking at the effect of HRT on the metabolic syndrome, then the increase that we see for HDL cholesterol is greater with oral than with transdermals. That's a beneficial effect. But a reduction in triglycerides is not seen with oral therapy. You tend to get an increase, but you do get a decrease in triglycerides with transdermal administration of estradiol. Insulin resistance is reduced with all forms of estradiol, but it's greater with the oral than the transdermal. And the androgenic progestogens blunt the HDL increase, they blunt the insulin resistance reduction, but they do reduce triglycerides. So there are one or two beneficial effects even from the androgenic progestogens. So the importance is to tailor the HRT regimen to the sort of metabolic effect that you need to see. And just to mention venous thromboembolism, because this is important, particularly in obese women. And here we know that for oral HRT, there is an increase. This is the big study from Vinogradova and her colleagues looking at the UK's GP database, research database, 470,000 postmenopausal women aged between 40 and 80. And what they showed, you can see on the right-hand panel here, there is a significant increase in VTE with oral, but not with transdermal HRT, as shown by the green bar here. Estrogen alone causes an increase in venous thromboembolism if it's given orally. And if you add any progestogen to it, there tends to be a greater increase in VTE. The biggest increase in venous thromboembolism was seen with a combination of conjugated equine estrogens plus medroxyprogesterone acetate. And the only combination orally not to show a significant increased risk of venous thromboembolism was that of estradiol combined with dydrogesterone. So if we look at giving HRT to women who are obese, the oral estrogen is going to have a plus point in increasing HDL cholesterol and in improving insulin resistance, but it's going to have a minus point in that it will increase triglycerides and it will increase venous thromboembolism. If you give the estrogen transdermally, on the plus side, that will reduce triglycerides and you will not get any increase in venous thromboembolism. But on the minus side, you get less of an increase in HDL and less of an improvement in insulin resistance. You still get some improvement, but it's just less. So in conclusion, what I hope I've shown you is that obesity is clearly linked to an increased risk of both coronary heart disease and diabetes. The menopause induces adverse changes in many metabolic and cardiovascular factors that will increase the risk of cardiovascular disease, and that will be superimposed on the effects already there from obesity. So treating obesity may well reduce the future risk, certainly of coronary heart disease and of type 2 diabetes. Treating the menopause may improve metabolic risk factors and also reduce the future risk of both coronary heart disease and type 2 diabetes. The important thing is to tailor the HRT regimen according to the metabolic status, and particularly with obese women, we've got to bear in mind the risk of venous thromboembolism that is already increased in these women. And probably the most important thing, of course, is actually to try and treat the obesity. A very difficult thing to do, but something that my good friend and colleague, Professor Santiago Palacios, is shortly to address. Thank you very much.
Yeah, thank you, John, for this brilliant lecture. Thank you. I think everybody in the audience has learned a lot. And I want to talk with you about the questions that came up in the audience. So there was the first question, I think it came up when you showed this meta-analysis about insulin resistance and menopause. Was the ethnicity of these women? So was there a difference in ethnicity in them?
No, these were all white women from the UK. So
okay.
there weren't any Asians or other ethnic groups.
Okay, good. So there's one question I think we should address later because it refers to what kind of diet one should recommend to women with obesity. So I think maybe Santiago will enlighten us about this topic. But there's another question for you, and it is, would the increase in VTE be the same for women with lower body weight and not necessarily living with obesity?
If you are overweight, you do, without actually being officially obese, you will still get an increased risk of venous thromboembolism. But the more fat you have, the bigger that risk is going to be. So if you can get your weight down, you certainly will reduce that increased risk of venous thromboembolism.
Yeah, which means, according to that question, that the VTE risk is much higher for women with obesity plus taking HRT, right?
If they're taking oral HRT, yes, that is absolutely right.
Yes. Now there's a next question. Does HRT help in reducing HbA1c in diabetics?
Yes, it probably does. I mean, there are different effects of HRT in diabetic patients, and there's not been so far any good evidence that HRT will reduce cardiovascular events in diabetic women. The fact that there's not been any evidence so far doesn't mean to say that it won't. There's more absence of evidence rather than evidence of absence, and we'd need much bigger studies to show this. So yeah, I think that in terms of the effects on diabetes, by and large, HRT, if it's given correctly, is going to be beneficial rather than harmful.
Yeah, thank you for this really clear response. So there's another question which kind of has to do with all our lifestyle. More recent research suggests that alcohol does not improve cardiac health. Would you please comment on that, John? Or can we stick to our one glass of red wine every evening?
I think certainly you can stick to your one glass of red wine at least every evening. There's always been, it's a difficult one because the epidemiological studies have shown there seems to be a J-shaped association between alcohol intake and cardiovascular risk, so that people who are alcohol free actually do have a higher incidence of cardiovascular disease than people who drink alcohol. But then the more that you drink alcohol, that's going to start increasing your cardiovascular risk again. So you've got to find a happy medium. So your one glass of red wine, I'm sure, is absolutely, as long as it's good red wine.
Okay, yeah, it's always good red wine. So you know Professor Herbert Kuhl, of course, and he always used to say, if somebody smokes, he should at least also drink alcohol. That makes it better, right? Would you agree to that?
I would agree to that as long as they stop smoking.
Yeah, yeah, I see. Well, there's a very nice comment. It says, thanks, Professor Stevenson, for a very clear presentation. And I totally agree with that. And then she asks, at the recent EMAS conference, I learned high HDL levels after menopause don't matter as HDL doesn't function well. In addition, what is more important, low HDL or high TG in terms of CV risk?
Well, yeah, they're both important is the answer. And it depends, different studies. I always used to say that at one time when we looked at all the studies that have been carried out, that low HDL was more important in North America and high triglycerides were more important in Europe. Whether that's still true or not, I don't know. And the answer is, of course, it's both of them.
Okay, thank you, John, for this very nice answer. And I just want to send you the greetings of Professor Anagnostis, whom you referred to several times, and he sends you greetings for your excellent presentation. So he's obviously listening.
Very kind of him.
Okay, I think so too. So I think for reasons of time, we will now transfer to the next presentation that is given by my friend and colleague, Professor Santiago Palacios from Madrid. He's the director of the Palacios Institute of Health and Women's Medicine in Madrid. And in addition, he's the president of the private assistance section of the Spanish Society of Gynecology and Obstetrics, president of the Spanish Foundation of Women and Health. Santiago, I wonder how you ever handled all these many presidencies. And sorry, you're professor of universities and head of masters at the Distance University of Madrid. And you are also a board member of the IMS. I think this is really very important, and that's why we are listening to you today. You have received 2 recognitions from Dr. Honoris Causa. Dear Santiago, I'm very happy to moderate your lecture, and we're very, very keen on what you tell us about how to manage obesity in menopausal patients. And I hope that we are much happier and well, and wiser after your lecture. Yeah.
Well, thank you, Catherine, and thank you, John. Thank you, Juan, for this beautiful talk, and you introduced very well my talk today. These are my disclosures. I have not really any problem here in this presentation because I am a board member and this is an IMS meeting. And well, I'd like to discuss absolutely the management of the obese women during menopause. But before this, let me first to emphasize that the obesity is a chronic relapsing disease. What does mean that the majority of the World Organization, they recommend immediate actions because this is in reality a global epidemic. No doubt that we need to take action. And not only this, if you look this beautiful slide done by our friend Rosella Nappi, the weight control is one of the most important concerns that we have in menopause. A lot of the women, they are concerned about the weight control, and we need to take this action in this way. We know that this is not very simple, obesity, and when you look at the adipocyte dysfunction, you need to understand that, of course, aging is going to work to have an important role there. Lifestyle changes is another issue, and of course, hormones. And this is exactly the reason for this talk today. And not only this, if you analyze one of the big problems that we have thinking in the long term weight loss is how we can maintain. Because maybe you are going to have beautiful effect in the beginning, but then the problem is to maintain this weight loss. This is exactly the issue. Professor Stevenson presented a beautiful talk about cardiovascular risks and obesity. But I need to emphasize that there are some other disorders that the obesity increased clearly. In our area, we can say a lot of this disorder. For example, urinary incontinence could be one. Other is breast cancer is another. All of the cardiovascular effects too. Well, so many. That means that when you like to see obesity, or you need to understand more obesity, we need to prove that obesity is going to be a disaster for so many disorders. But before going directly to the recommendation, I like briefly to speak some words about the most important question that I am sure that the majority of you have in your brain. The first one is, how does menopause affect fat mass obesity? Other is, how does obesity affect menopause? If there are some benefits or more risks when we use menopause hormone therapy in obese women, if there is or not, or there are, any relation between menopause hormone therapy and GLP-1 analogs having better result, or maybe no. And then I will go directly to the recommendation, but it's going to be very briefly. Let me start with the first question. This is a beautiful slide when you can see that when estradiol during the perimenopause years is going down, look here, the visceral adipose tissue is going up. And this is exactly, as you can see here, exactly the body mass index by DEXA. In conclusion, we have clear that during menopause, fat mass is going up and lean mass is going down. That means that this is exactly the problem that we have during menopause. During the perimenopause and early menopause, fat mass going up, lean mass is going down. And in this slide, I can summarize the answer of these questions. When estradiol decrease, the abdominal subcutaneous fat increase and the visceral fat increase too, with the typical inflammatory and cardiovascular risks. Move on to the second question. And how does obesity affect menopause? Well, this is another slide, beautiful slide, where look, for example, the rose, the pink line, and the green line. During premenopause years, the obese women, they have perhaps less estradiol levels, but after menopause, they are going to have more estradiol levels than women with a body mass normal, with a normal body mass index. This is a slide to understand the estradiol levels in relation with body mass index. But I like to summarize with this slide done the last year for a beautiful paper for Dr. Tang. Is both obesity and abdominal obesity are related to severe or frequent vasomotor symptoms and anxiety symptoms. If the question is, obese women, they are going to have more vasomotor symptoms and more severe, the answer is yes. And as Professor Stevenson presented, it's clear that other big problem is going to be the life expectancy that is in relation with the body mass index. Well, move on to the third question. Benefits and risks of hormonal therapy in obese women. The first point is to see this beautiful slide. Professor Stevenson presented very well that how estrogen play in the women body in terms of metabolic health, the energy balance, and if the estradiol decrease, of course, you are going to have more risks of obesity, the adipose health, and all of the different parameters. If you see this slide, you can understand that estrogen play a good and important metabolic role. If you remember, I think that some of you with my age, they are going to remember the result of the PEPI trial 23 or 26 years ago, the famous PEPI trial. But this is a beautiful slide that you can see that after 3 years, women with estrogen, only estrogens, or estrogen plus progestins, they are going to have better weight change than the placebo group. They reinforce the idea that HRT or menopause hormone therapy is going to be okay in this way. Now we know more and more details. We don't know exactly the reason or how estrogen work in terms of fat tissue, but we can say that probably estrogen play an important role in the epigenetic regulation of adipogenic genes. I was reading some papers like this to show that we know more details, small details about the estradiol mechanism of action in the adipocytes. And perhaps for me, the most beautiful slide is this one, because I can summarize the majority of the papers. The binding of estrogens to the estrogen receptor alpha of the white adipocyte increases lipolysis and decreases lipogenesis. In other words, estradiol has a positive effect in the adipocytes. But let me to say more practical or more realistic. What are the recommendations in this moment about hormone replacement therapy in the obesity, during the obesity or in obese women? We can say that although estrogen is not recommended for the treatment in relation with to decrease abdominal obesity, it is likely to result in favorable change of body composition, no doubt. And progestogens with lower risk of BT, as John Stevenson said, they are exactly recommended. We are speaking about micronized progesterone and dydrogesterone. And finally, we prefer estradiol as estrogen, and transdermal administration could be much better. Move on to the next question, that this is some very challenging question. If we know what's happening with the combination in obese women between menopause hormone therapy and GLP-1 analogs? The answer is no. There aren't any paper. I wrote one editorial the last year, and I exactly put these two questions. If I add a GLP-1 analog to the menopause hormone therapy, what exactly is the efficacy of the menopause hormone therapy? Is maintained, is improved, or worsened? And exactly with the body mass index, we don't know the relation. Sure, that the next year we are going to have more data with some other groups. But well, in this moment, we don't know the relation between menopause hormone therapy and the use of GLP-1 analogs. And come on now to the last part of my talk about the recommendations. There are so many recommendations around the world. One of the reasons that I am here is because the Spanish Menopause Society, we did one beautiful recommendation the last year, and now we are thinking to do something similar with some European colleagues. I like this part to start with this beautiful slide about the effect of weight loss on different metabolic parameters, and in fact, of the adipose tissue biology. This is very nice to recognize and to accept that as more weight loss, you are going to have more beautiful result in intra-abdominal adipose tissue or in the free fatty acids, etc. That means that the proportion of weight loss is going to be fundamental, one of the issues too. In this other slide, we can see exactly something similar, is to say that this could be the conclusion of this part, greater weight loss leads to improved health outcomes. Well, if you decrease 10, 15%, you are going to decrease dramatically the risk of some big problems of cardiovascular disease or urinary stress incontinence. That means it's important to weight loss, but it's very important the percentage of weight loss. Well, come on, go directly to what we can do when we have in our desk one obese lady. First is to do a beautiful history, no? The typical medical history, the typical good anamnesis about the majority of these parameters. Always we need to start in medicine with a beautiful anamnesis. And of course, we need to do physical exploratory that we can see exactly everything, not only blood pressure, we need to see if there is or not hirsutism, or maybe to know exactly if they are stride, or maybe acanthosis nigra. Well, you know well what we can do. But one of the most useful questions during the symposiums is about the diagnostic screening. The majority of the recommendations are done in relation with the body mass index, but the waist circumference is going more and more, in fact, the majority of the endocrinologists expert, they say that it's easier and probably better to measure the waist circumference than the body mass index. But now everything, all of the recommendations are in relation with body mass index. Could you see as simple could be the diagnosis that is only to measure the waist circumferences? And if it's more than 80, well, you can take action. This is something very simple. Of course, we have some other techniques, but all of these techniques, they have some limitations. The majority of them, they're in relation with the price. But maybe all of these techniques, the majority of the doctors, they use for research, as for example, DEXA or tomography or a resonance magnetic one. You know, well, you can measure fat versus lean mass with all of this technique, but this is not necessary. The majority of us, we think that with the body mass index could be enough, or the waist circumference. Of course, we can measure some other parameters, complementary examination in women in the transition to menopause with obesity. Some of them, they are very usual, lipids, electrocardiogram could be, hepatic enzyme and so on, the most simple one. But well, there are some other that are optionals that you can measure too. If you have some, if you think that maybe it's going to be important for the diagnosis, or maybe for some other reasons. Of course, we are going to have so many barriers. Lack of recognition of obesity is one. The problem that we have with the communication, the time that we have with our patient, lack of reimbursement, the price is another. Of course, we understand that this is not an issue way, no, but well, we need to try. Of course, when after all of this, you have a diagnosis and you need to decide what to do. The first thing, with no doubt, and this is the most important one, is to change the habits. And of course, diet and exercise, they are fundamental. And of course, elimination of bad habits too. These three pillars, they are exactly the reason for the start with the treatments or the recommendation. But if you look at this slide, this is beautiful and very practical slide. This is the recommendation done by the majority of the international societies in relation with obesity. Women between 27 to 30 kilograms per meter square body mass index, you can recommend the diet, activity, and behavior. But if they have comorbidities, maybe you can add some drug or pharmacotherapy. No doubt that in women with more than 30 until 35, both pharmacotherapy and diet activity, they could be the recommendation for treatment. And finally, in women with more than 35 body mass index, maybe you can think to speak about some other ways surgery is. This is exactly the recommendation by the majority of the societies. Very simple, and you have here clearly. We need to accept that there are some drugs, some different treatments, some different possibilities with different mechanisms of action. Auristatin is one of them, naltrexone plus bupropion is another, and the GLP-1 analogs with liraglutide, 3 milligrams on the head. Perhaps this is exactly the, as you know, the new GLP-1 analogs. They are there. They are very well accepted. We are using a lot in the world, and this is one of the issues that maybe we need to emphasize for the future, as I said before, is to know more about the activity during menopause of the GLP-1 analogs and what's happened with HRT, with the menopause hormone therapy. We can say that the liraglutide, 97% is similar to the human peptide. And if you see here this beautiful slide, how works the mechanism of action in a very simple manner is that, well, the satiety is increased with liraglutide and hunger is decreased. Of course, the mechanism of action is very complicated through the brain, the hypothalamus, the nucleus arcuatus. But well, you can see here exactly how it works in a very simple manner. There are beautiful papers that are here, that there are so many studies to show that after 10 months, you can decrease more than 10%. That means maybe this is a very consistent studies, there are so many of them, they present this possibility. And this is how the Spanish Menopause Society decided to put exactly the ideas that we have women with more than 27 and with comorbidities, or women with more than 30 kilograms per meter square of body mass index. First, you need to start with the idea to work with the diet, physical exercise, and so on. And then you can think in a drug characteristic that could be liraglutide as the first step, or maybe if no, you can think in orlistat or in another combination. We know that in some countries it's ready for obesity, the semaglutide, but we have not ready yet in some others, as Spain, but it's coming and with the same result, more or less, with a weight loss of around 17%. This is very similar to liraglutide, but well, perhaps to use one time per week would be much better than to use every day. This exactly is the idea of these GLP-1 analogs, no? Well, you need, of course, to start with no any drug, but maybe if it's necessary, you can add this drug and to trade to our women with this GLP analogs. The other day in the European Menopause meeting in Florence, the symposium was fantastic because more and more my colleagues, they have beautiful experience with the use of the GLP-1 analogs. And this is the last slide. This is exactly as Johnson Stevenson presented, a call to action. We have the possibility to work with our menopause women that they need the help to decrease weight, to decrease loss. We have preventive measures, we have therapeutic measures, we have the combination, and the only thing is now is to work in this way. And let me to finalize with this slide. I am IMS board member, and I need to say, please, we are going to have our World Congress in Melbourne the next year in October. You need to put $1, €1, £1, what you prefer, day by day to have money to be with us. And thank you so much.
Yeah, thank you, Santiago, for this excellent presentation. And also thank you for the invitation to come to Melbourne. We start saving our money from now on for that, don't we? Okay, so dear Santiago, and also dear John, there are a number of questions which I think for reasons of time we will not be able to address all of them. I have one little comment, Santiago, because what you mentioned, the difference between BMI and the waist circumference. Well, from my experience, every woman with a BMI over 30 for sure has a waist circumference of more than 80 centimeters. So I'm not so sure if you really have to make this differentiation, and BMI is much easier to kind of find out. So
this is an important point because I was surprised the other day in the Spanish Obesity Congress, where the majority of the doctors, they say that perhaps in the future is going to be more important the ways to measure the circumferences more than the body mass index.
Well, I was just wondering about that fact, because we do measure the waist circumference, and we just see it's very high in any woman with overweight or obesity. So what I want to give you some more questions, and there's also a thank you to Santiago for this excellent, amazing presentation. And we also have listeners from Mexico, and I want to share with you the question. It is said that by only losing 5 to 10% of weight, we decrease insulin resistance and improve other markers of CVD risk. Is this also valid in morbid obesity? That is a question. I don't know who of you two will answer it, but maybe first Santiago.
Well, the answer is yes, but if it's a morbid obesity, they need to wait more. The percentage is not enough. Between 5 to 10% is not enough. And the problem is going to be there. Probably is in these cases, this is the reason for having surgery there and to decrease more than 25, 30%. That means that, well, this is not bad because always if you lose weight, this is okay. But we need more percentage than 5 to 10. Okay. I think that this is not enough.
Yeah, I think that's a very important issue, Santiago, that our thresholds to kind of transfer patients with morbid obesity to surgery, our thresholds should become lower, I think.
It's going to be lower. Absolutely agree. Absolutely agree.
Yeah.
But well, but now this is the recommendation. Now they are there.
Mm. Yeah, so there's one important question that again to you, Santiago. Would HRT be contraindicated with liraglutide?
No, no idea. Well, no idea because but there is not any contraindication. But John and myself, we recommend more transdermal. Age is the major risk for VTE. Obesity is another major risk for VTE. If oral estrogen, they have some risks of VTE, please don't use oral route and use transdermal route. It's not a real 100% recommendation, the contraindication, but it's a recommendation to use transdermal estrogen more than oral estrogen in women with obesity.
So I think we all, three of us agree that if a woman is obese with a BMI over 30, we would certainly only give her transdermal estradiol. But still, would it be okay together with liraglutide?
I think so. One of the problems is we have any paper with the combination between liraglutide and menopause hormone therapy. And this is exactly the point. The point is that we need papers and results to know what's happening with this combination. And exactly if, for example, liraglutide is going to work better in women that are using menopause hormone therapy would be beautiful, but we don't know yet.
Okay, so there's a question, maybe this I will address to John, who's still there, and that is HRT contraindicated at any BMI level? So would you give HRT to a woman with a BMI of, let's say, 45 or 50?
I think if she needs it, yeah, I think I would do. Obviously, again, that would definitely be going for the transdermal there.
Of course.
But yeah, we can't deny, I don't think we should deny HRT to anyone who has a real need to take it. If she's got a symptomatic need, then she deserves it. But she also needs to be persuaded to lose weight as well. And just on the point of should you be aiming for the 10% reduction in weight, that it's not so much based on benefit, it's more based on reality, that most patients, you can probably get them to aim for a 10% weight loss, but to get them to aim for more than that becomes very, very difficult. And they very quickly get discouraged and just give up. And then they go and gain more weight.
Yeah, thank you for this answer. And there's something that actually that kind of goes into that direction. There's a question about if you have made with medication a loss of weight in the patient, and the patient does not change her lifestyle and her dietary adjustments. So will she go back, and she will go back to old behaviors, and after stopping the medication, the weight will change drastically again. So I think that is the yo-yo effect, right? Santiago, do you agree?
Yeah, yes, the point is that, yeah, this is one of the how we can maintain the weight loss. The maintenance of weight loss is the issue. I agree with this point, but only I think that the medication is to stimulate the change of the habit. It's for me something, if you take and you lose some weight in the beginning, maybe you have more illusion for change your habit and to start with a real new life. That means that this is for me the issue and the answer of this question, that this is more than question, this observation that I agree with it in general.
Yeah, so so we have to work on everything, like, you know, trying to giving them help with medication to lose some weight, or at least educate them to better lifestyle. I think we have to start with this education of lifestyle very early, not only in menopause. I think you all agree with that. So I'm looking to the time, and we have just finished this hour. There are a whole lot of questions more, and I think we have answered a lot of questions. Again, there are a lot of thank yous for the congratulations for this great seminar. Thank you for a very informative presentation. So thanks to these two excellent speakers. And well, I had a lot of pleasure listening to you. I gained a lot of knowledge from that, and I hope we see again soon. Not only in Melbourne, Santiago and John, but maybe earlier.
No, earlier.
I'm sure. So I thank everybody for listening, and it was my great pleasure to be moderator of this meeting. Again, there are a lot of, well, a lot of congratulations in the chat, and so I say goodbye and hope to see you soon. Okay, thank you.
Bye-bye. Thank you.
Bye.